piece, just you note that all these are easy for you to remember. How did the pain start? When is the pain? How long was the proptosis? The past, any past medical history, which is very important in a case of proptosis. What is the direction of the proptosis? Palpation for any mass, pulsations, and periorbital changes have to be looked into. Periorbital changes are also very important. So pain can be due to inflammation, infection, hemorrhage, and also tumors growing along the nerves, as in a pleomorphic adenocarcinoma. Pain in an orbital abscess, the child will be very sick, and it will be relieved only when you drain the pus. But in a case of a subperiosteal abscess, the child will not be that symptomatic, and it's usually in the medial side. It's adjacent to the ethmoid, and there will be a smooth dome-shaped swelling because it's under the periosteum. The pus is under the periosteum, and the medial rectus will be pushed laterally. In orbital cellulitis, there will be, you all know the symptoms. I'm just highlighting the points that you may not remember. There may be fat stranding, that is, the septa between the fat will be prominent. You can see a fat stranding in the CT. There will be fussy borders of the muscles, and also the lacrimal gland will be elongated oblong, and that will be ill-defined, and the tendon insertions will also be involved. And when do you do a CT in an orbital cellulitis? In the textbooks it said when there is limitation of orbital ocular movements, when there is a proptosis or pupillary dilatation. But we do a CT after we start systemic steroids and antibiotics after 2 days. Because then after the edema subsides, you can see if there is an abscess, if there is a swelling underneath, etc. So, but if there is sensation loss, you have to think of orbital apex syndrome, and then you have to do an MRI or CT more urgently. Pain can also occur in myositis, where there will be a restriction in the opposite direction to the involved muscle. That is, if the medial rectus is involved, the patient will have defective abduction, and the muscle will also be enlarged on CT. Deep dermoids can occur in adults also, where you can see swelling thick-walled cyst with layered contents, because the fat in the dermoid will layer down, and a clue that it's long-standing is you can see bone excavation. I don't know if bone excavation on the right lower CT. That is a clue that it's long-standing and it's a dermoid. In lymphangioma, if it bleeds into the lymphangioma, the patient can present with the subconjunctival hemorrhage and acute onset of pain and proptosis. So this is the most important slide in this presentation. Progression is very, very important when you encounter a case of proptosis. If it is within hours, okay, hemorrhage, you will know. Within 2 to 3 days, orbital cellulitis or any inflammation. Even within 1 or 2 weeks, you have to think of inflammation only. But in tumors in children can occur within 4 to 6 weeks, that is 1 month, 1 or 2 months. And adenocarcinoma, lacrimal adenocarcinoma will present to you within 8 to 9 months. And if it is more than 1 year, it could be a lacrimal adenoma, a lymphoma, or a cavernous hemangioma. These are small tips that you can, these are the common tumors only. So this is adenitis with an enlarged palpebral lobe of the lacrimal gland, and a S-shaped ptosis is classically seen with limitation of abduction. This was a tumor with leukemic deposits, and the patient presented in 4 to 6 weeks. And always do mass in orbital mass in children, always do a peripheral smear and a fundus examination, because that itself will give you a clue as to what it is. And a bone eroding mass in a child could be a Langerhans cell histiocytosis, or a localized form is an eosinophilic granuloma. In lacrimal adenocarcinoma, which has seen, the patient will present to you in 7 to 8 months, there is bone erosion, and they will always look at the temporal part of the forehead look for altered sensation due to perineural invasion of the lacrimal adenocarcinoma. Progression more than 1 year, if it's a lacrimal gland mass, it could be an adenoma only, it's a rounded mass confined to the lacrimal gland fossa. And it could if it's an axial proptosis, it could be a cavernous hemangioma, and it could also give a history of increase during pregnancy. Molding masses, molding along the recti could be lymphoma, and it will be present for more than 1 year. It can present under the subconjunctiva also. It's called a salmon patch. So how do you do an exophthalmometry? We usually use a Hertel's exophthalmometer, where you keep the exophthalmometer on both the lateral orbital rims, and you can see there is a prism on both sides where you can see the distance of the cornea, the projection of the cornea from the lateral orbital rim. You can see the anterior surface of the cornea. There are two lines, red lines there. So you have to coincide these two lines. And you keep the same bar reading when you are measuring the proptosis, so that you can compare the increase or decrease later. And when you are measuring exotropia, you can take either a 2-scale method, or here I am using only 1 scale. You measure the distance of the displacement of the pupillary reflex from the center point on the forehead. You can keep 2 scales. That will be too cumbersome. You may require an assistant. And hypotropia can also be measured like this. So what are the errors? You should rest the lateral, this thing without tilt on the lateral orbital rim, and also ask the patient to look at primary gaze. So proptosis, you can know the different, what the causes from the different directions. In axial proptosis, it's usually a cavernous hemangioma or a thyroid. And lateral displacement of the eye, you should look at the canthus also. If it is displaced, then it's under the bone. The cause is under the bone. It could be a mucocele. So down and out proptosis, frontoethmoidal mucocele. And ethmoidal mucocele, frontoethmoidal mucocele is classically described as a smooth fluctuant swelling which is mildly tender. Down and in proptosis, adenoma, it could be a palpebral lobe mass or an adenoma, and if the lacrimal gland tumor grows posteriorly, the proptosis can become axial. Hypertrophy in a maxillary mucocele. Extraocular movement should be looked into. The pulsatile proptosis, it's usually missed. You have to look under the slit lamp to see the pulsatile proptosis. Sometimes it could be neurofibroma when it pulsates along with the brain pulsation, and it could also be a caroticocavernous fistula, where you can see enlarged anterior ciliary vessels and a dilated superior ophthalmic vein in the CT. Don't miss that. And also abduction is restricted. Why is abduction restricted? Because the 6th nerve is closely related to the carotid artery in the cavernous sinus. Orbital varices, you have to take a CT with and without a Valsalva manure. The CT should be with and without Valsalva manure, then only orbital varices may be prominent. There may be increased orbital volume, phlebolith and enlarged superior ophthalmic vein can be seen. So CT is always preferred for orbital surgeons because you can see the bone. But MRI can be done if you are doing, if you want to detect orbital apical lesions or intracranial extension. So you have to look if it takes up contrast. Capillary hemangioma takes up contrast very well, whereas a cavernous hemangioma does not. And is it homogeneous or heterogeneous? Is there bone erosion or excavation? These are the points that you have to see in addition to the extent and all that. Thank you.
Thank you, Dr. Annie, for this beautiful pictures and wonderful presentation.